I'm going to talk a little bit about general principles that will help you get a little more comfortable with prescribing antibiotics, I hope. Maybe more confusing. This is often one of the most daunting aspects of advanced practice, and especially since there's been an emergence of microbial resistance with antibiotic use, it adds another layer of responsibility as prescribers. Not only do you need to determine how to treat the patient, but you also have to be very cautious conscious of antibiotic resistance and do things to help control and combat microbial resistance. Some of the things that you can do as practitioners are, of course, avoid indiscriminate use or misuse of antibiotics, use some adjunctive agents to help protect against antibiotic inactivation, and sometimes even use combinations of antibiotics. We'll get into things like that later as we go through the rest of the unit. Um, this is obviously a problem that's in evolution, and I'm sure we'll all be witnessing some changes to pharmacologic interventions with regard to infectious disease over the next few years. Bacteria are one-celled organisms that have a primitive nucleus and a rigid cell wall. These structures are porous to low molecular weight molecules. Gram-negative bacteria have a more complex cell wall than gram-positive bacteria do. The cell wall structures are going to affect the ability of antibiotics to penetrate the bacteria. Whether bacteria is aerobic, meaning requiring oxygen, or anaerobic, meaning it doesn't need oxygen, will also help you determine where in the body a bacteria is best going to thrive. This type of information is also some of the information that will help guide you in your decisions when selecting antibiotics empirically, meaning without the benefit of a culture. Some terms and definitions. Antibiotics are products of living organisms that kill or inhibit the growth of microorganisms. Antimicrobial or any naturally occurring or synthetic substance that kills or inhibits the growth of microorganisms. Bacteriostatic antibiotics have the ability to inhibit growth and replication of the bacteria, but the body's immune system is required in order to immobilize and kill the organism. Bactericidal is the ability of bacteria to is the ability of an antibiotic to kill bacteria independent of the immune system. The minimum inhibitory concentration, or MIC, is the lowest concentration of an antimicrobial agent necessary to inhibit growth of an organism. Then the minimum bactericidal concentration, obviously the MBC, is the lowest concentration of an antimicrobial agent necessary to kill the organism. Intracellular bacteria are bacteria that retain the ability to reside and replicate within cells. Examples are Salmonella, Legionella, Mycobacteria, and Chlamydia. Extracellular bacteria reside and replicate outside of cells, like strep and staph and Pseudomonas. Beta-lactam antibiotics are drugs with structures that contain a beta-lactam ring. This ring must be intact for antimicrobial action to occur. And these beta-lactam antibiotics are penicillins, cephalosporins, and carbapenems. Beta-lactamase is a bacterial enzyme, or are bacterial enzymes, that hydrolyze the beta-lactam ring of the certain penicillins and cephalosporins. Beta-lactamases are the penicillinases and the cephalosporinases, and the ACE obviously being enzyme. Beta-lactam inhibitors are potent inhibitors of some of the bacterial beta-lactamases. So these used in combination with other antibiotics can help to protect the hydrolyzable penicillins from inactivation. Penicillin binding proteins, or PBPs, are bacterial cytoplasmic membrane proteins that act as the initial receptors for penicillins and other beta-lactam antibiotics. Peptoglycans are the chain of polysaccharides and polypeptides that are cross-linked to form the bacterial cell wall. The spectrum of activity refers to the specific organisms of class, or the specific, that doesn't make sense what I wrote there. The specific organisms or classes of organisms for which the antibiotic agent is considered to be generally effective. So narrow spectrum antibiotics are effective against a limited number of organisms. and they're unlikely to disrupt the normal flora because they just target specific organisms. Broad spectrum antibiotics are effective against a multiple number of organisms, and they're also effective against more than a single class of microorganism. Um, and of course, you really want to generally use the more specific antibiotic, the more narrow spectrum if you can, if you know what your organism is, rather than do broad spectrum antibiotics. Gram positive versus gram negative. Knowing whether an organism is gram positive or gram negative will help to guide your decisions in picking an antibiotic. The terms gram positive and gram negative refer to the way a cell stains. With a staining dye. Gram positives retain the dye and appear deep violet under the microscope, and gram negative organisms don't retain the dye and they still appear kind of red under the microscope. The reason for the difference is that gram positive organisms have cell walls that have a low lipid concentration. Gram negative organisms have cell walls that are high in lipids. And since many antibiotics exert their activity on cell walls, knowing what type of cell wall will help narrow down your treatment to determine which antibiotics will be more effective. Cultures and sensitivity testing. Typically when you're treating an infection, you see somebody with pneumonia or UTI, you start empirical treatment based on what you think the most likely suspects of bacteria are. And generally you do a culture and sensitivity on the specimen to determine specifically the organism that you're treating, and also to determine which antibiotics the organism is going to be most susceptible to. But then again, you usually obtain the specimen and start empiric treatment. You usually don't wait 48 hours if you've got an infection brewing. The culture is done by collecting the specimen, then plating it on agar and allowing it to grow so that they can identify the type of or organisms. And then the sensitivity is going to be determined because they'll take little pieces of agar or like a felt that are impregnated with antibiotics, and they'll plate those around the agar where the bacteria is growing, and it takes like 2 days, and then they'll look around those little spots to see if the antibiotic inhibited the bacterial growth. And so when you get your report back, you'll have the type of bacteria or the types of bacteria reported, and then you'll have a sensitivity report. And it'll usually report sensitive, meaning the antibiotic inhibited the growth of the microbe and would be effective against the bacteria. If it says intermediate, it means that some of the bacteria was inhibited, but not all of it, by that antibiotic, so the antibiotics aren't going to work completely. And then if it's resistant, it means there is no inhibition of the bacteria by that antibiotic impregnated material, so the tested antibiotic is not going to work with the specific bacteria. And usually it'll have multiple antibiotics listed, and whether or not they were S, I, or R. And so you want to look at those after, even if you've started an antibiotic, but you always want to check your culture and sensitivity to be sure that you're treating them correctly. And if you're not, then you need to switch them to an antibiotic they're sensitive to. And remember, these tests are in vitro. They're not in vivo. They're not in a live person. So there's going to be other factors that affect the effectiveness of the antibiotic. Then overuse or inappropriate use of antibiotics contributes to the development of resistant bacterial strains. Why do we overprescribe antibiotics? Sometimes it's a lack of knowledge on the provider's side. I think it's more often a lack of knowledge by the patient, and providers cave in either because they fear losing their patients, or if they don't give them what they expect or want, they'll be angry, give them bad reviews. I don't know. And I'd rather treat a patient appropriately and have them mad because I, didn't give them an antibiotic than treat them inappropriately and have them mad because the antibiotic didn't work because it wasn't necessary for whatever they had. I think it's more important to educate our patients as to why we do or why we do not think they would benefit from an antibiotic. And I find sometimes that if I personalize it, like I'll say, if this were my child, I certainly would not give them an antibiotic at this point because I think this is a viral illness that would not respond to an antibiotic. And you have more risks from the antibiotic than benefits, et cetera, et cetera. Or if this were my husband, or if this were me, I would treat it like this. Um, and I think sometimes if you personalize it, they believe you a little better. As long as you're being honest, don't make it up. Okay, and then also I know that people have just come in. If they've gone to the ER, they've paid a huge chunk of money. If they've come into my office, they've paid a copay, or they've paid an out-of-pocket expense, and I know they're leaving empty-handed. They're leaving thinking, "Gosh, I'm going to have to go somewhere else if I'm not better, or I'll have to come back and pay again." So I usually give them an option there so that they don't feel like they're just hanging out without you know a definitive treatment if something goes awry. So, and granted, sometimes, that ear can get worse, and actually require antibiotics. But I usually, have patients just drop back in. And don't get me wrong, most providers don't do this, so don't think it's the norm. But I usually have them drop back by if they're not better, and I'll listen to them again or recheck their ear again or, whatever I need to do. And I don't charge them for that quick, second look. Um, and so I'll tell them that they have that option before they leave, and rarely, but every now and then. But I try to reserve this for rare situations. I'll give them a prescription that they can fill if they have changes that make them more suspicious, or me more suspicious that it's a bacterial infection. And I'll also give them my phone number and let them call me. But I find that most people that have that that advantage of another option without worrying about having to go make another copay or pay an ER visit, leave happier without their antibiotic, and they also know that they have another, recourse if they get worse. And we all know how expensive it is to go to a provider. Plus the antibiotics and the other OTC drugs and everything just really add up. Remember that resistance patterns differ from community to community. So what you see in one city, you might not see in another. And people within the same communities will usually see the same organisms passed around. So you want to consider the patient's potential exposures. Like, do they do a sport? Are they wrestling on a mat with a bunch of sweaty guys and passing MRSA around? Is everybody in their family sick with the flu? Do all the siblings have strep throat? Is everybody in the classroom sick? Things like that. And you also want to culture the organisms or do a test to confirm whenever possible, like flu screen or strep screen or culture of an infection. And then also share the results with your colleagues so they'll be aware of the organisms and the resistance patterns of the community. For a while I was seeing getting positive flu screens. So I kept asking the peds people upstairs if they were seeing flu, and I was seeing 4 and 5 a day, and they weren't seeing any. And I think they just weren't testing, or their testing stuff wasn't working. But anyway, it's good to know what's going on in the community so that you'll know that different bugs are there. And you can also check with your affiliate hospitals or labs, and they usually do, I guess they all do, an antibiogram, which is a summary of the bacterial isolates that are sent to the lab for culture and sensitivity. And the lab will generate a report listing the common bacteria and the common antibiotics that they're sensitive to, and you can use that as a clinician to base your empirical treatment on, and assess the resistance in the community. Whether their patients are getting appropriate or inappropriate antibiotic prescriptions, bacteria that is exposed to an antimicrobial, whether it's appropriate or not, will still develop resistance. So some of the mechanisms of resistance I'm going to touch on. Acquisition of genes. These are mechanisms of resistance. Acquisition of genes that can produce enzymes that inactivate antimicrobial agents. Acquisition of efflux pumps capable of draining the antimicrobial agents from the bacterial cell prior to any bactericidal or bacteriostatic effects. And this mechanism can contribute to multi-drug resistance, like MRSA. acquisition of several genes capable of eliminating the antimicrobial binding site during the synthesis of the bacterial wall. Mutations can occur in the gene that encode the target protein so that it no longer binds to the drug. These are random events that create an advantage for the bacteria. And this mechanism of resistance doesn't actually require exposure to a drug. Bacterial mutation can occur via transformation, conjugation, and or transduction, which results in resistant bugs. Transduction is when a virus that contains DNA infects bacteria that contains plasmids of bacterial DNA that contain genes for various functions, including one that provides for drug resistance. Incorporation of the plasmid makes a cell resistant and capable of passing on that trait. Transformation involves the transfer of DNA that is free in the environment into the bacteria. And then conjugation is the transfer of DNA from one organism to another during mating. And over time, this exchange of genetic material is making the antimicrobials less effective. Again, every time we treat with an antibiotic, the susceptible bugs may be killed, but the other resistant bugs that are hanging out along with it will continue to grow and multiply, creating more resistant bacteria. Okay, antibiotics, mechanism of action. They can be classified as bacteriostatic, which means inhibit growth, or bactericidal, which means the bacteria is killed. They exert these actions through several different types of actions, mechanisms of action. They can inhibit cell wall synthesis, like beta-lactams, penicillin, cephalosporins, and carbapenems. They can have a direct action on the cell membrane, altering the permeability, allowing a leakage of intracellular material. For example, the bactericidal action of polymyxin and nystatin. They can affect the ribosomal subunits to inhibit protein synthesis, causing a bacteriostatic action, as can be seen with tetracycline, erythromycin, clindamycin, and chloramphenicol. They can cause binding of ribosomal subunits to alter protein synthesis and cause cell death, as can be seen with the aminoglycosides. They can alter metabolism of nucleic acid to cause the bactericidal effects seen with rifampin, the quinolone antibiotics, and metronidazole. And they can block essential metabolic steps by antimetabolites, for example, the bactericidal action of sulfonamides and trimethoprim. And they can inhibit viral enzymes that are essential for DNA synthesis through nucleic acid analogs that produce bacteriostatic activity. Some general treatment principles. First of all, treat only if a bacterial infection is present. You want to consider the most cost-effective antibiotic. Otherwise, they're not likely to purchase it if it's like it's super expensive or just not cost-effective. You want to look at the antibiotic that's likely to be the most effective. You want it to have the narrowest spectrum to cover the infection. You want it to have the lowest potential for toxicity and the least potential for allergies. Okay, so just some general thoughts. And then prophylaxis, a lot of people say, can you give me something just in case I get sick or my wife's sick, I need to take an antibiotic? No. That's not how you treat infections. First of all, prevention is the most essential step, and that means good hygiene, hand washing, and healthy behaviors. Just keeping yourself healthy, your immune system will function better and you'll be more resistant to getting sick. There's only a few situations where prophylaxis with an antimicrobial may be warranted, and that's sometimes with some STD exposures, HIV post-exposure prophylaxis. Some people that have high risk for infection, like patients that are on chemo, people that are undergoing organ transplant, and they're on all those, like on steroids and stuff to lower their immune response. And so sometimes they'll put those people on antibiotic prophylaxis. I know a patient of mine I just saw the other day had been getting chemo, and they put her on Levaquin for like a week every time she has her chemo. And as a clinician, it's prudent to treat patients according to generally accepted guidelines. And it's not only prudent because it's the way your patients are most likely to get treated correctly, but it's also the easiest to back in court. If you ever get sued, if you have actual published, clinical guidelines, then you're going to have a better argument if you're dragged in and sued for something. You can find these in numerous locations. The Infectious Disease Society of America, the National Clearinghouse, the CDC, and the World Health Organization all have guidelines for treating infectious diseases on their websites, and there's also many, many more. So once you've established a diagnosis and you determine that an antimicrobial agent is going to be appropriate treatment for a patient, you want to consider again the likely suspect that you're treating. For example, with the urinary tract infection, you consider that E. coli is at the top of your list. With sinusitis, you think the most common pathogens are going to be strep pneumonia, H. flu, and MCAT. And these are the same pathogens that are typically responsible for community-acquired pneumonia in healthy adults. Anyway, you want to consider the likely causative organisms and then aim your treatment at those likely suspects. You want to consider drug and patient characteristics after selecting your treatment, or when you're selecting it, not after. You want to consider allergies and other issues that may affect your patient's ability to tolerate a medication. I see a lot of, for example, I see a lot of oil field workers who are out in the West Texas sun all day, every day. They never get a day off. And so I always consider the potential for phototoxic reactions. So I don't usually use doxycycline on these people. After seeing one bad phototoxic reaction to doxy, I don't want to see another. Also, if a patient has, strep throat, but they may have other symptoms that may make you suspect mono, you want to avoid treating with amoxicillin because it's really common for people with mono to break out in a bad rash when they take amoxicillin. And it's not an allergic reaction, it's just characteristic of the disease. And if the patient's symptoms have just started, like say they just started having a sore throat and fatigue, etc., a mono test isn't going to be positive because it takes a good week or so to develop antibodies for the test to test positive. So, just because they test positive for strep does not exclude mono. Because I think it's 10% of patients with mono also have a positive strep, and I've seen this a number of times, probably 10% of the time. You also want to consider things like, the taste of the antibiotic, like when you're prescribing a liquid to a child. They always want the pink stuff because it tastes good. Some of the chalkier stuff really doesn't. You also want to think about whether or not the patient can take pills or requires liquid. And that's not only children. I mean, sometimes I have adults that have problems with pills. And some of the larger pills, like when my mother was sick recently, they prescribed her some pills that I couldn't even imagine swallowing them. And she was already having trouble swallowing. You have to think about things like that. And again, not everything can be crushed, So consider the possibility of, GI side effects. Do you give somebody erythromycin? I never do because they all have GI side effects. If I have to use macrolide, I'll use Zithromax or rarely clarithromycin, but azithromycin if I have to. I never use erythromycin. Also consider the distribution of the drug. Some antibiotics will not penetrate some sites in the body as well as others. For example, some drugs are highly protein bound and they just won't get into sites of infection. Lipid soluble drugs will penetrate the blood-brain barrier and can be used to treat CNS infections. So you have to think about things like that when you're prescribing. Also consider the way the drug's metabolized and whether the patient may be on drugs that interact with during the metabolism. If the patient has chronic kidney disease, they may need some drug doses adjusted for the GFR. If the patient's immunocompromised, it would be preferable to treat with a bactericidal antibiotic instead of one that you just, kind of calm down, but it's still there. Compliance must be considered also. So when you look at prescribing a drug that's dosed QID, who's going to take a drug 4 times a day? I know the last time that somebody prescribed something to me 4 times a day was the last time I ever prescribed a drug 4 times a day. So, if you can give them something once daily or twice a day, you're going to get much better compliance. Then you also want to, of course, consider the severity of the illness. Um, when you're looking at how to treat. I mean, some people need more than an oral antibiotic and need to be hospitalized. And then again, sometimes if you're using something like Levaquin, you have the same bioavailability or roughly the same with an oral dose as you do IV. So if it's, you may be able to kind of, do a trial of outpatient treatment. And then you also want to look at concurrent illnesses, um, or chronic diseases that can affect drug delivery, like if they have heart failure, um, as well as, they also have an increase for potential drug interactions if they're on a lot of drugs. And, if you use Hippocrates, that, they have a quick, drug interaction checker, and I use that all the time, even with things I'm pretty familiar with, because sometimes I'm surprised. And remember, you're not alone. Fortunately, you're practicing in the 21st century. It wasn't that many years ago that we did not have access to online resources. I mean, I used to have to carry books, okay? And now there are resources and clinical guidelines and specialists to consult with everywhere. Not that there weren't specialists when I started. I'm not really that dark age. But, there are, resources available at your fingertips. And I honestly think that it's probably, not using resources and having proof of your, your treatment, or your practice, um, what am I trying to say? If you don't use like a current resource and you're going to have a harder time arguing it in court. I think, we're going to be held to a standard of care that's a little higher since everybody does have electronic resources at their fingertips. I think that's what I was trying to say. The decision on how long to treat, first of all, you're going to find that in your clinical guidelines. It usually recommends a course of, X number of days, depending on what you're trying to treat. And if the antibiotic was started empirically, but the culture comes back and doesn't grow anything out, that's the time when you can stop the antibiotic. If the culture comes back showing a susceptibility to another drug, but not the one you started with, which does happen, don't feel bad. Just stop that drug and start them on the other. And generally tell the patients to complete the full course of treatment, mainly to reduce the potential for antibiotic resistance and treatment failure. Some infections, can be treated with topical agents, like eye infections, vaginal infections, some skin infections. Abscesses need to be drained. One of my pet peeves when a patient comes in to see me for an abscess, and they were seen in the ER or another urgent care clinic or something, and they were treated with antibiotics. If there's pus, it needs to come out. It's not going to get better until you drain it. Now, there's some things that you won't drain. I mean, you're not going to drain an empyema or an intra-abdominal abscess, but if you see something with a skin abscess, it needs to be open. The pus needs to be drained. And also once you start prescribing, and you start seeing, if you see a patient with antibiotics associated complication, which you will, like a super infection, like C. diff colitis, and I had a lady that had drug-induced hepatitis with Bactrim. She was, of course, the most popular nurse in the hospital and came in extremely fatigued and extremely yellow after she had like 2 doses. Anaphylaxis, yeah, I've caused that before, and it wasn't in drugs that the patient had been previously allergic to. So those episodes are going to make you far more cautious about your prescribing practices, make you leery. So over the next few chapters, we're going to cover treatment of specific infections and also look at the different classes of anti-infective agents and get a little more familiar with those and get some practice writing prescriptions for infectious disease. So we'll see you on the discussion board.